a webinar called the Evidence-Based and Clinical Use of Mobile Applications in Behavioral Health. This event is sponsored by the Coalition for Technology in Behavioral Science, CTIBS, as well as the APA. Joining me are our two guest speakers, Dr. David Cooper, who's a psychologist at the Mobile Applications Lead. He's the Mobile Applications Lead at the National Center for Telehealth and Technology. Dr. Myron Pullier is a psychiatrist and clinical associate professor at Rutgers, New Jersey Medical School. We'll be talking about apps today, and I want to tell you a little bit more about me as we get started here. I am the executive director of the Mental Health Institute, and I'm also the president of CTIBS. Some of you may have been familiar with my work in the past at the APA. I started in 1995 and have been working through various groups at the APA to help advance the responsible use of technology. CTIBS is an outgrowth of a lot of that work. We are an independent nonprofit at this point, and we are an interprofessional group that is focused once again on the responsible use of technology. So this webinar is in line with our goals, and we were delighted to be invited by the APA to co-sponsor this event. I'll be starting our conversation I'm going to need some help to move that slide forward. I'll be starting the conversation with just a brief review of our learning objectives. We'll help you plan a path towards including mobile behavioral health apps in your clinical practice. We'll help you recognize ethical issues raised in dealing with apps. Based on explicit criteria, we'll help you judge the pros and cons of apps, and we'll help you recognize the importance of becoming familiar with each app before using it with patients. Now, all of you in the audience are muted, and if you have questions, I want to encourage you to type them through the chat box, which you'll see on the interface here. And I want to encourage you to do that as we get started, because they may not occur to you at the end of the session when we'll try to leave some room for questions. Also, all of us are able to see the questions as they come through, and if we see a question there that we can address as we're going through our content, then we'll do that. So it's useful for you to go ahead and type your questions in as they occur to you. So the first topic I wanted to bring to your attention is just the size of the market and what the predictions are. It's quite evident to lots of people, lots of different publications, that it's growing very rapidly. But what current predictions are, and this is through a study by Research to Guidance, published in 2015, that the market will grow by $31 billion in the next, well, what's left of the time period till 2020. That's phenomenal growth, and we can expect then that our clients and our patients will be asking us more and more about which apps to use and whether they're safe and a number of related issues. What we're also seeing is that a number of the larger insurers are considering the use of technology, including different apps that can be made available through a variety of new technologies. Here's just a recent article published on April 22nd of this year that talks about how the smartwatch may still be struggling to find its place in the mHealth ecosystem, but providers and payers are finding ways to make it useful. This is a new app that's been released to help remind patients about medication and when they need to be taking them, and their reporting of taking them as well over time to the practitioners. So there are a number of useful applications that we're seeing our insurance companies embrace. The big question, though, is what makes a good app, and how can clinicians responsibly start prescribing these apps and using them with people on their caseloads. So we're seeing here a recent article by Fast Company that brings up the very question that I and a number of my colleagues have been bringing up at the American Psychological Association convention every year for the last 5 years. Actually, I've managed to organize a panel presentation and to bring some experts in from around the country to talk about this at our annual meeting for the APA. And that's going to be the focus for us, our conversation here today. My interest in this work started several years ago when I tried to identify principles of risk management for choosing apps. This followed my trying to summarize the apps I could find through my website blog, which is at telehealth.org/blog. And what eventually happened as a result of that was I was invited by past president, APA president Jerry Kuchar, to write a book chapter on it. I knew Myron for years before that, so Myron and I teamed up to write this particular chapter on mHealth applications for psychologists in the 2013 version of Jerry's book, the Psychologist Desk Reference. In that chapter, we outlined the 7 criteria that include the ones I've got listed here today. So let me go back to that first slide. Okay, so the issues that we considered were started with usefulness, the applicability. Does the app adequately cover the range of tasks required to satisfy an actual need? Some apps claim to do things, but they really don't. And if they do them, they don't do them safely. So that idea of usefulness, it was a big one. The second one that we looked at was, is it usable? Is it practical? Does it meet workflow requirements? Does it save time for the user? The usability also has to do with the technical architecture of an app. For example, if you put 5 buttons on the bottom of a screen and somebody, an app, you know, on a smartphone screen, and somebody tries to click those buttons, if they have relatively thick fingers, they may hit 2 buttons at one time. That is an issue of how that app is constructed. Also, does it use up a lot of energy? So there are a lot of issues related to usability. Interoperability was another issue we identified. Can people use an app to enter information and then have their other devices reflect that data entry process? Or do they have to go repeat all of that stuff again in the other device using the same app? So interoperability is becoming more and more of a pressing issue to be thinking about. Security. If the app communicates with us as clinicians and connects us to the patient or the client, does it have to be secure? Well, yes, it does. As a matter of fact, the state of Georgia, just in October of this last year, required that all of their clinicians get trained in using technology of any type. They call it their telemental health rule. And I wrote to them and I said, well, does that include apps? Because some apps do connect with clinicians, and they responded to me in writing and said, yes, indeed. Apps do have to, anybody using an app in the state of Georgia that is a licensed social worker, counselor, or MFT needs to take 6 hours of training to learn how to use technology appropriately. And a lot of that has to do as well because these apps have to meet standards. And one of the standards that we teach in that type of course is HIPAA compliance and also state compliance on top of HIPAA for security. So there's a lot involved there, to the point there that state has now made a requirement for people to get 6 hours of training. The 5th issue we identified in that book chapter was validity. Does the app measure what it's supposed to measure? And a lot of us have had a lot of training about reliability, so you kind of probably recognize that validity issue as well as reliability. Does it perform consistently over time? And then, of course, the other issue we threw in for risk management was informed consent. Do you properly inform your patient or your client about the risks and benefits of using this? And that includes installing the app on a mobile device in your office, or helping your patient or client install it so that you can teach them the defaults and how to navigate through that. So what's happened over the last few years is that a small group of us at the Telemental Health Institute have gotten together to review apps and to perfect these 7 criteria. So we have a much more elaborate system at play now, and Dr. Pullier will give us more details of that during his presentation. So next, I'd like to introduce Dr. David Cooper, who is a psychologist once again and the mobile applications lead at the National Center for Telehealth and Technology. He leads teams of designers and developers to create mobile apps for the U.S. military around behavioral health and traumatic brain injury. Dr. Cooper.
Thank you, Marlene. Hi, everyone. As I said, I'm Dr. David Cooper. Before I begin, my government employers would be remiss if I did not say that I have nothing to disclose, and these opinions are of my own rather than the DoD, who I work for in my day job. I'm here on behalf of CTIBS to help educate you all today. So let's start off by talking about some statistics on mobile app use, just to give you a breadth of what we're dealing with here. So as we know, according to the wonderful Pew Internet study, 72% of users are looking online for health information, and over half of smartphone users have been able to download at least one health-related app and are using that throughout the day. So do you know where your patients are looking? Do you know where to help them find quality information? And how do you as a clinician help them distinguish the good from the bad information so that they can make sure they're getting quality products? There are over 165,000 health apps on the market today. Excuse me. That's a lot to review and be aware of if you're a clinician trying to figure out how to get your hands around some of this stuff. 65% of them connect to some form of social media. So helping patients understand the impact on their privacy, who can see their data, how to be able to manage that is going to be important for both you and your patient to be able to help facilitate that relationship. 10% of these apps connect to wearable devices or sensors, and this number is only increasing. How many of you would say that you're familiar with the kinds of data that wearables can add to apps, or things that are available like heart rate, breathing? They now have EEG devices that connect via Bluetooth to apps. So these kinds of data that previously weren't really available in the kind of clinical milieu because, well, we didn't have a good way to connect, get them, are now going to become increasingly more available and relevant to your practice because you have access to this data. But on the other hand, about 36 apps account for over half of all downloads. So really the cream is rising to the top in these apps. There may be a proliferation of them on the market, but users are learning through popularity. Clinicians like yourselves are learning about these applications and being able to share that with their clients and patients to really let the ones that are beneficial rise to the top. And so for you, that means you can learn just a handful of apps and still be able to manage this. You don't have to learn 165 and be familiar with that many apps. You just really have to know a handful. And of course, in the past 2 years, it's increased by 106%. So, we know this mobile health trend, apps in treatment, is going nowhere. This is going to be a increasingly relevant issue for you. And yet, how many of you were trained in using technology? How many of you working in academia have clinical programs that train new psychologists in using technology with patients? This is really something that we're trying to address at CTIBS and at the DoD to try and engage clinicians and give them some kind of training on how to use these apps, how to introduce them in treatment, and really to understand how to evaluate them for quality in using them with their clients. Just to talk about some of the benefits of apps, and again, why you should be paying attention to these and using them. Apps can provide more ecologically valid data for working with clients. You have a greater ability to collect user-generated and automatic data. one of the hardest things for me, and I think for probably many of you, is seeing patients and actually getting them to fill out those nice little handouts that we send home with them. If it's on a mobile phone, well, they're going to have access to that wherever they go. They're going to be able to enter that. They're not going to leave that behind as they might a piece of paper. And it's going to get you better data as you'll be able to get it throughout the week rather than waiting for them to fill it out just before they see you. And increasingly, we're going to be able to get automatic data, so we won't have to rely on user-generated data at all. It will be automatically captured, taking the burden off of the patient and yet giving you a richer quality of data to be able to have access to. It's going to give you, mobile apps can give you increased touch points given your shrinking clinical time. We all know that we're having less and less time to see with patients as we have to write notes, meet clinical requirements, legal requirements. So if someone has their phone with them on an average, I think, of 22 hours a day, think of all the hours when people are not in your office. Mobile apps are really going to give us an unprecedented opportunity to be able to intervene and gather data. An example of this is an app we make called Breathe to Relax. It teaches diaphragmatic breathing, and it allows for patients to learn this outside of the office on their own time. So you as a clinician can assign this kind of app for review and learning and use your clinical time to address other salient things rather than necessarily using it for skill building. You can promote your alignment with patients in treatment. Again, these things are only increasing. Patients want mobile apps. They want to be able to use mobile apps in their treatment, and it's becoming an increasingly expected tool in healthcare. Yet, if you can imagine, if someone comes in and says, hey doc, I have this great app, I have this great data from my Fitbit, and wants to show it to you as part of their healthcare, or even bringing in genetic data, some of this other kind of data we're able to collect now, only to be dismissed. I mean, how would you feel if you kind of say, no, that's okay, that's not important, I don't want to deal with that? You're really going to dishearten the patient and reduce that alignment with them, because you won't want to or be able to work with them in the way that they would like to. You can introduce these kind of apps early in the stepped care model. So again, with something like Breathe to Relax, you can prescribe that prior to intake. As soon as somebody says they're coming in for an anxiety issue, you can use an application that is based on evidence-based treatment like diaphragmatic breathing to provide them some immediate relief for anxiety, even before they ever come in your office. Finally, dealing with meaningful use criteria. Stage 2 criteria and the clinical quality measures that we're all going to have to pay attention to as part of the new meaningful use clause. Really, I think mobile apps are probably going to be the only way that we're going to be able to effectively and accurately gather data for things like patient and family engagement, care coordination, efficient use of resources. That's really going to be one of the big drivers as far as a benefit that you and your patients will see from using these mobile apps. So let's dig right into the actual evidence base for using these apps in treatment, and looking at some kind of key issues, studies that represent key issues, and then talking about your use of clinical judgment versus the actual evidence base as this area grows and becomes more developed as a research area. So first off, I want to talk about these two studies here. Basically, the thing to take away from these studies is something very simple, a small but important issue that the psychometric properties of assessments, when delivered via smartphone, are really going to be the same if they're used as originally intended. So if you use a previously validated assessment in the way it was intended as part of your mobile app, you can still consider it psychometrically valid. There are no issues around that are going to cause the results to be distorted, cause you to have to question this. So this is it's a small but very important issue to realize. Going back to what Marlene said, of course, issues like usability and how the assessment is delivered are going to be very salient. However, if you can see that it's presented in a way that is satisfactory to you as a clinician, you can be assured that the psychometric properties of the assessment will be as they originally intended. This is another good study. It's an overall review of various studies out there, talking about various kinds of digital interventions. It's nice because it's very wide-ranging in terms of the technologies that it examines. It ranges from websites and mobile apps to serious games and virtual reality, talking about giving a good overview of studies that are out there and available. Most of the review is spent on web interventions, mostly because there are more studies and RCTs for web intervention and around longer. But as web and mobile are merging, what we're finding is that lessons from the web and web-based interventions are easily translated to mobile interventions. And so we're seeing that these kinds of digital interventions do provide short-term benefits for a lot of the disorders that are commonly seen in treatment. This also gives you, this article is also very good because it gives you a good overview of the landscape of the types of interventions available, and as well as issues coming up like big data and passive data collection, and how those will impact your treatment and be used in the treatment of behavioral health issues. These are two studies done by Colin Espy out of the UK, and one of the reasons I include these is because one, they're one of the few RCTs that are been done on an application that's available both on a mobile device and the web. Another reason is that Sleepio, which is an online intervention for insomnia based on CBT, is a popular product that many of you are going to hear about. So understanding that the research behind this and that it is efficacious in treating insomnia based on CBT will be important. So this can be one of those ones to keep in your pocket as far as things that you can recommend to clients that you know have been validated and that are effective. Another reason to mention this is because in the UK, Colin Espy is not bound by the rules of the FDA. So I think this kind of issue represents a good challenge that maybe many of you haven't thought about, is that in the world of globalization and internet connectivity, not everything will be bound by these same sorts of regulation, and that it only becomes more incumbent upon you as providers to understand what is validated and what is not, and not just necessarily assume something is going to have to adhere to FDA. It also makes a challenge for researchers in that in some ways other folks are less hampered than we are and can get interventions and test them in ways that we cannot. So that's going to be a challenge for researchers as far as how to keep pace with this kind of global availability of these kinds of apps. This last one is a good, more recent overview indicating similarly good effect sizes for digital interventions around mindfulness. This one looked at about 15 different RCTs and showed that online mindfulness interventions have, a good small but significantly beneficial impact on depression, anxiety, well-being, and mindfulness, all with kind of Hedges G around 0.22 all the way up to 0.32. So that kind of effect size shows that, again, they're not going to be overwhelmingly effective for those interventions, but on the par with many of the interventions that we're already using. The biggest thing that this found that mindfulness interventions were beneficial for was for stress. The effect size there was 0.51. So recommending apps like Headspace, like Mindfulness Coach from the VA, that are based on evidence-based mindfulness interventions, you as a clinician can be reassured that these kind of evidence-based developed tools will be efficacious, just like mindfulness is, teaching it inside the clinic. So these are kind of just some quick overviews out there And we're seeing a kind of few trends here. There's lots of pilot studies and some RCTs. Looking at specifically for mobile, we're still early in terms of the research process. Yet, even though we're well into the adoption curve for the public. They're generally positive, and they generally show that web-based interventions that are translated to mobile are going to be as equally positive. There is, of course, more research needed. Mobile has yet to meet the same level of evidence as other interventions available. There's also a lot of shoulds and few did papers. So what I mean by that is there's a lot of papers describing what people should do with mobile applications and what studies should be done, rather than actually RCTs and evaluating actual applications. This is because, of course, apps are expensive, and most researchers are not good app designers. So it's a lot easier to write opinion papers than to do RCTs. This may also be indicative of an overall lack of funding. Grant committees are probably not likely versed in the technology needed, because to develop these kinds of applications and interventions, you really need to take a more cross-disciplinary approach and bring in people from outside of our field, like human-centered design or folks from the computer science department, to really get the benefits and explore what these applications can do. So to that end, I think part of where we are right now is, as the evidence base grows, we're still going to have to rely a lot on our clinical judgment. And this is really for a couple of reasons. One, the pace of technology compared to the pace of research. Technology is moving a lot faster than we can research it. So we, at least in my program, what we try to practice is something called evidence-based development, working with interventions that we know already have a solid evidence base, like diaphragmatic breathing or mindfulness, and figure out ways to implement those in mobile apps. And finally, asking yourself, will it harm the patient? Certainly there is a lot of snake oil when it comes to mobile apps and mobile healthcare apps. Some can be outright dangerous, some can be just more benign, and you may want to weigh the actual clinical benefits of the application versus how much it may hurt your alignment with the patient if you were to kind of out and out refuse them. To speak to the pace of technology versus research, I just want to show you these statistics, and that I think this really highlights what we're dealing with here. I can build an app on an average of 18 weeks, but to complete a typical RCT is going to take 3 to 5 years. I think that this is important because unless we can drastically reform the way we're conducting science, which of course is a whole nother webinar, you as clinicians are going to be behind this curve for a long time. There are going to be a lot more apps out on the market than are actually validated. And so you're going to have to rely on your clinical judgment and be familiar with the application more than you will be able to point to specific RCTs or specific applications that have been validated. Another thing to think about is that, so thinking about evidence-based development, consider who made the app. Is it reputable? Was it made by a university or another organization? And understanding the evidence base behind the application will be important as well. I mean, how many of you can cite the research showing that information on handouts, presented in handouts and videos, are effective? And yet, how many of you regularly provide those to clients? So as long as thinking about mobile apps as just another platform for delivering the same kinds of psychoeducational intervention. And many of the apps on the market are simply geared around that, providing psychoeducational material to clients with a few tools. You can start to think about how apps can be one more tool in your tool chest to present the same kind of evidence-based information that you are already presenting to clients. You'll need to be familiar with applications and using your clinical judgment and whether or not it will do harm. There are applications out on the market. I think there was a news story probably a few weeks ago that I saw where some bipolar applications on the market claiming to be for bipolar information had some pretty negative kind of pieces of advice in them, such as, well, if you can't fall asleep, why not go have a drink? I don't think any of us would want to recommend that to our patients. And yet anybody with a Google account or an iTunes account can develop and put up an application. So understanding actually what is in the application, whether or not it will do harm. Lastly, I just want to touch on one other issue, and that's FDA approval, which is another reason this is going to be a difficult time for you as a clinician as we try to catch up the research base to where it needs to be. Nothing we ever do in our field, unless some of you are psychiatrists, is going to be addressed by the FDA until we put it in an app. So by putting it in an app, the FDA is going to consider it a medical device. And really, they're not really good guidelines as to how this process is going to work. There's not even really a category to apply under in medical devices. General to apply under neurology. So really, this shows you that you're going to have to be relying on your clinical judgment as the evidence base, as the FDA catches up. So it's something that's going to be important for you to be attentive going forward. And now I will actually hand it over to Myron.
Okay, that's me. I have nothing to disclose, unfortunately. A little bit too academic for that. I'll be talking about engagement and ethics and evaluation, repeating some of the stuff that Dr. Cooper has just said. He showed how mobile behavioral health apps can be effective tools that are worth including in clinical practice. Alcohol is a great deal of fun, and it's worth including in your life, according to a lot of people. It's dangerous to drive with alcohol, but most people get away with it quite nicely, and it's the same to be said about apps. Despite all the dangers, generally people get away with using even apps that are not so great. Apps that are not effective could still be effective because they have a tremendous placebo effect. They make you feel like you're doing something active. You're taking charge. You're putting yourself into the hands of somebody who's developed the app and who knows their stuff, supposedly. So that does put the clinician into a great deal of difficulty because apps are attractive, and yet there are all sorts of ethical problems, dangers for the patients, a learning challenge for the clinician, and difficulty finding good enough apps to integrate into an actual treatment plan. But it still is time to get into apps. We're pretty much past the early adopter phase, and clinicians really need to get familiar with an assortment of apps for various purposes. For example, oops, skip that. There we go. Here's an app that guides motivation. For people who can't see it, this is an image of a donkey being guided by a carrot on an iPhone. So let's look at 3 ways that behavioral health clinical practices are engaging with apps. Then we'll get at some of the ethical issues again, and after that I'll describe the scientific approach that our task group is developing for evaluating and selecting apps. Okay, come next. There, good. Picture this, a patient mentions or asks about an app, maybe directly or maybe timidly in passing, just a hint, like, I have a friend who's been using this app and who said I should get it. In fact, the patient may already be using it. There it is. An app has entered the treatment situation. There's no avoiding a response. As far as the patient is concerned, the clinician will come across either as approving or as putting the app or the patient down. Same with your kid coming home smelling of tobacco or alcohol or pot for the first time. Your response or non-response communicates something. Suppose a patient asks about an app and a clinician says, I don't know. What does that mean? I don't know much about apps, or I don't know about that particular app, or I don't approve in the sense of I don't care about apps in general, or I just don't approve of that one. Is that clinician out of touch, worried about losing control of the therapy? It may be helpful to ask how the patient is using it, or what are his hopes for the app, and what has he heard about it. What if a patient asks for a suggestion for an app that would help, a recommendation? Again, I don't know is not the greatest answer, and it is not meaningless. What would be a more helpful reply? How about this? So far, I haven't seen an app that seems safe enough and good enough to be worth trying right now, but more and more apps are being developed and tested. If you or I come across something that may be promising, let's look into it. The third way to include an app is to embrace it. Embracing apps could involve cooperating with the patient's use, collaborating by discussing results formulated by the app, such as by reviewing printed reports, or accepting data streamed electronically to one's office, or by taking the initiative and prescribing an app with or without subsequent close interaction. Asking patients to use an app prior to intake amounts to prescribing it. So we just told the patient we're looking for an app that is safe enough and good enough to try. So this is all about ethical issues like safety, patient empowerment, and how to evaluate an app. So, safety first. App developers should ensure that users can and do control the confidentiality of information about the app's use. Using an app to track some shameful behavior, this has to be done discreetly so it won't be overheard, read unencrypted on a mislaid or stolen cell phone, or picked up by an electronic eavesdropper on a free Wi-Fi network at a Starbucks or an airport. The patient needs to be told about these dangers. Suppose a patient downloads an app about, say, diabetes or bipolar disorder. Some potential employers will pay a hacker or a data broker good money for that intelligence so they can hire someone else or not hire that patient's parent or child in order to avoid medical insurance costs and sick time issues. A good published review would check out an app's confidentiality and privacy protections, allowing a clinician to decide if the vulnerabilities outweigh the app's potential benefits. Just as we have ways to live with the vulnerabilities in our email, in our browsing, messaging, social media, we can handle apps safely enough if we know how. Speaking of vulnerabilities, however, most patients are particularly vulnerable to abuse. And there certainly are abusive apps. Which brings us to maleficence, causing deliberate harm, the opposite of beneficence. We know that people can and do suffer direct harm from information technologies, from the internet, and potentially from apps as well. Bullying has resulted in severe dysfunctional states and suicide. The media report all sorts of scams, identity theft, seduction, etc. As far as actual clinical decision-making is concerned, however, most apps that have been produced by or recommended by healthcare people and organizations are very unlikely to cause trouble for a given patient. Even so, is it ethically okay to guide patients into dangers unprepared? Someone who doesn't ordinarily use email, browsers, messaging, Facebook, there really are such people, and pushing them into the wild west of the internet in order to use an app can mean trouble, even if it's not directly from that app. Besides, if we prescribe an app or okay it, and something bad happens, even just on a news report to somebody else, the patient's disappointment or resentment of us could undermine treatment. Does the promise of benefit based on personal experience, app reviews and studies, or an experienced eyeball evaluation outweigh the risk of harm? That's always a tough guess, but it's a question we have to ask about any clinical intervention. It may be useful to have some specific informed consent documentation available that explains how to minimize the risks posed by apps and by any sort of online activity, including how to deal with arousal of strong emotional states by a potent and well-intentioned app when the patient is not in immediate contact with us. Even if we happen to be discouraging a patient from using some particular app and not recommending it, a discussion about apps in general may legitimately fall within the scope of the treatment plan. Of course, informed consent for a prescribed app is part of this, but helping the patient to consider using or not using apps in general can be not only a direct benefit, but it can also be a way to partner with the patient and family as active agents in planning and effecting an overall treatment approach. Beyond informed consent, this is a matter of patient empowerment, of attention to the patient's welfare beyond the presenting complaint or main focus of therapy, a way to define and strengthen the working relationship by dealing with a professionally relevant issue. Even if the decision is not to use an app, giving consideration to the patient's having asked about it, or a patient's misgivings about using one that's prescribed. Taking this seriously shows respect and sensitivity to the patient's preferences and tastes. If nothing else, an app can be a sort of transitional object or a token, an exercise in reaching an agreement that, if you will, can train the patient into agreeing with, adhering to, elaborating, actualizing, or generalizing other matters in the course of treatment. As I suggested, patients will be thrusting apps upon clinicians, which calls for clinicians to expand the boundaries of their competence as per APA guidelines. This means becoming sufficiently familiar with the issues to estimate and discuss benefit and harm, risk and risk avoidance, beyond just being able to say that some app seems too untested or too odd or likely to be a distraction from real therapy. More generally, apps can be a gateway to engaging with telemental health methods in one's own practice. Taking training at professional meetings or online is a good way to develop competence in delivering care ethically through the available technologies. So, some concrete advice. Before integrating an app into therapy, practice using it as a patient. This does not include joining an online group of users and pretending to share the same issues, or even revealing that you're just there to look around. That would be disruptive. For an app where you would interact online with the patient via your computer or mobile device, learn the features, where all the buttons are, where the ropes are, and how to undo errors. Practice with a colleague or someone in your family. Electronic communication with a patient, which goes beyond a brief telephone call, changes the professional interpersonal boundaries that may be essential for treatment. Interactions tend to be less formal, not as confined to time and place, less constrained by immediate concerns about consequence, and more prone to misinterpretation and projection. Therapists Googling patients and scouring their Facebook postings is likely to come across as intrusive and offensive. Yet patients often turn up all sorts of personal information about their therapists that we would rather they did not have. Professional caution in one's online presence, all over the place, online. This is important, and this applies to interaction via apps as well. The topic of online presence of patient and therapist is something to address with patients proactively in a well thought out, expanded, informed consent-like intervention. Here's a point that we push in our telemental health training and our textbook. Think of informed consent as an ongoing process, not just that old 20th century one-shot cover-your-ass form signing ritual. Actually, a discussion about including technology in treatment can be a neat way to define the entire professional-patient relationship, to spell out what treatment is, how it should work, and what we would do if it's not going as well as expected. Ethically, all of this should rest on the foundation of science. Are apps evidence-based? APA's guidelines for the practice of telepsychology is worth checking out. They apply to all aspects of using or even tolerating apps. Guideline 1 okays using technology for a patient even without scientific evidence of efficacy, as long as the clinician judiciously considers available information about safety and usefulness, documents this, and informs the patient of the status of the app. Of course, there is good science behind an app. If there is, that's a plus. Basing an app on magic, some fringe theory, or even on the latest fad is a minus. An app should apply its underlying scientific theory appropriately in its design and in its interpretation of data to qualify for use in practice. If outcomes research is available that increases an app's desirability, great. However, an app should also suit the patient's culture, tastes, and preferences. How could a clinician find good enough and safe enough apps? Consultation with colleagues is one important way and could provide insights into how to use an app and for which patients to use it. Consumers' comments on download sites can be surprisingly helpful if taken with a grain of salt. But going deeper into evaluating an app, discovering unacceptable flaws, such as poor encryption or misleading information, looking critically at research conclusions, aggregating reviews, and making comparisons with alternative apps. For this, we need knowledgeable professional reviewers who will address all aspects. I mentioned being part of a task force working on how to evaluate mobile behavioral health apps in a scientific way. We are convinced that the best route towards actually unrealizable ideals of scientific proof, ideals that we can't really meet, but the best route towards that and towards excellence in apps is experience that is guided by these impossible ideals. To that end, our group is putting together a reviewer's toolkit consisting of a dictionary of review criteria, a reviewer's workbook, a reviewer template, and a review database. A brief description of this may throw light on the inherent nature of mobile apps. The dictionary is an annotated list of criteria, relatively specific items that may be rated or described, such as encryption, accuracy of information, or degree of efficacy reported. The annotations define each criterion precisely and provide discussion and even links to relevant publications. We're grouping criteria into more general qualities, such as ease of use or safety. Eventually, factor analysis may improve such grouping. We divide all of this into 4 quadrants. This is based on the hierarchical structuring of psychological theories that Luciano Labate, whom everybody should know about, he's written like 50 books. He's the father of all sorts of psychological theories. Luciano Labate was developing in several of his books this idea of quadrants. Dr. Labate was working with us on this until shortly before his death last month. Dr. Labate's insight helps us to identify the paradigm behind the app, its assumptions and notions, its essence, what it's supposed to do for a user. For example, the developers may assume that app users who keep describing something they find unusual in what they are seeing around them, if the app user does this, that this will generalize into some sort of mindfulness and will reduce rumination and worry. That's the assumption. A different paradigm may rely on entertainment and distraction to break up rumination. So our quadrant 1 set of criteria are for describing an app's paradigm. Let's see if I could do that. There we go, quadrant 1. In selecting an app, a clinician would look for a paradigm that suits the diagnosis and treatment goal and that fits the clinician's own theoretical persuasion. Quadrant 2 is for identifying a particular app under review. Labate's quadrant 3 addresses how the app affects its users. the bottom line for a clinician: usefulness, usability, interoperability with other technologies, security, validity, reliability, informed consent. Finally, the criteria in quadrant 4 address the mechanisms through which the app works, the technical aspects. We're constructing a reviewer's workbook in which a reviewer could record her observations about an app. This would be a data repository and a place for scratch notes. From this workbook, a reviewer would mine the data and write an actual review for publication. So we'll offer a template system to facilitate review submission and editing. Data entered into multiple reviewers' workbooks and held in a database could be compared. The data could be used to compile aggregate reviews to stock an app formulary, which would be a searchable resource for matching apps to the needs of particular patients, and for research into what makes for effective apps. The overall project also aims at defining standards for app development and for how to review apps. The app review field is at an early stage, but there are a few groups working in this area, notably one under the aegis of the American Psychiatric Association and another at the University of California, Davis. To sum up, mobile behavioral healthcare apps are ready for prime time, and clinicians are increasingly being called upon to include apps in working with patients. This requires expansion of one's scope of competence with special attention to matters of ethics as generally described by APA codes and guidelines. Apps can be a transition into other applications of technology in delivering care, including various telemental health services. It's a good idea to pick up some specialized training and to become familiar with a few mobile apps. There remains the issue of finding appropriate ones that are effective and safe. So we have task forces putting together methods for addressing this need for a science-based app selection. So the bottom line, engaging with apps is no longer just an opportunity. Apps are rapping on the door. And now, what? Marlene, take it from here.
Thank you, Myron. And also thank you, David. I also want to thank everybody in the audience. We have been deluged with questions. If you haven't yet asked yours, please do so. Type it into the chat box. We have so many questions that I think it would probably be wisest for us to try to answer a few of them here, but then to write them all out in a document and answer them in writing. And when we send you a link, when the APA sends you a link to see this recording, I believe it'll take a couple weeks or so, then we can include the document with that. We did have a question about slides, and slides can be included. We'll give you a link to the slides as well. So you'll have a whole lot of information. So once again, if you haven't yet asked your question, go ahead and do so. I'm going to summarize the questions that have come in. And while I'm doing that, I want to encourage you to write down the URL that we have underneath the word questions on the slide you're seeing now, tinyurl.com/ctibs-survey. We, on this call, are very interested in getting your opinion about app usage so far. We have over 1,200 people that have registered for this particular webinar. Even though the APA did not offer CEs with the webinar, we still have that type of need. So we'd like to take advantage of the ability for us to put some data together and possibly publish a paper about it. So please, if you would, write down that URL, tinyurl.com/ctibs-survey. And it takes about 4 or 5 minutes to answer. It's just, I think we have 5 or 6 basic questions there. Just clicking answers will do. And then we'll let you know the information that we gather there too. So the bulk of the questions have come in asking about one app or another. And we really don't want to name apps and say this one's good, this one's bad. You know, you can imagine that would put us in a precarious position. But looking at the questions that we'll get, we'll try to address them as best we can when we get them in a written format. We had one question come in that I thought was particularly important in terms of ethics, and that is my area of focus. So I'll address it and then ask you, Dave and Myron, if you have any other questions. But then we have other questions that have come in that I want to address after that. The first one has to do with just real hands-on. Should we use a hands-on approach to introducing apps with patients or clients? And the sort of normal response to that is yes. It's really best to sit with your client or your patient and have them download the app on their phone so they don't get frustrated by it later if they can't do it. You should be familiar with it, of course, and know how this works. And then a very important issue to pay attention to is that most app developers ask for permission to collect data, and usually they'll give the reason of in case there's a bug, so report the bug to us. But the truth is you never know what they're doing with the data they're collecting. And I'm going to address another question that came in line with the same issue. There is an issue of big data, and if you haven't looked it up, I strongly encourage you to do it, because there's all kinds of data that's being collected on all of us as we do a number of things, from buying gas at the gas station to buying coffee down at a coffee shop, and our movements are being tracked. It's our job as clinicians to protect our patients from unwarranted data collection about their behavior, especially the behavior that we're asking them to enter into an app, and that can be particularly sensitive information. So the usual request of patients is to consider toggling off that question that asks them if it's okay to collect their data, even if it's under the premise of reporting bugs. So you can actually open the app and then take them to that screen and talk to them about big data in general, and being mindful of any personal information, PHI, personal health information that they're entering into an app, even if it's just on their phone and not being communicated to you. So that brings up the question of a resident app, a native app that stays only on a person's phone, or the ones that might connect to us or to databases, or in this case to developers. It's our job to make sure that our people's information is safe. So that's something to be particularly mindful of. We've had a number of questions about FDA. So we've had a question about elaborating FDA. We have another question about are even educational apps subject to FDA review. I think, Dave, it might be useful for you to say a little bit more about the FDA and exactly how they're involved.
Sure. Thankfully, as a government employee, that's one area where I can actually speak to, because we've been having conversations with the FDA about how to handle this. So the FDA right now, this is a new area for them. They're dipping their toes in the water. There really is no good path forward. They're trying to balance not stifling innovation while at the same time trying to protect patients. That's their overarching framework that they're trying to apply. So what they've said is that there are different categories of apps. Typical psychoeducational apps that you all are probably thinking about fall into an area called Stage 2. And what the FDA has said about Stage 2 is that we reserve the right to review those apps. They're not going to out and out say you have to get FDA approval for those kinds of apps, but the FDA also wants to have in its back pocket the ability to punish people and remove apps from the market that are clearly fraudulent, or saying things that are potentially harmful. A good example of that is there was an acne app that said if you turn the screen on your face and shine it on your face for 3 times a day, it'll remove your acne. That's patently false, and so the FDA was able to actually say, no, you have to take that application down. Where we're moving is towards the Stage 3 applications, where treatment is actually being provided and apps are actually part of treatment. That is absolutely going to be subject to FDA review, and again, we don't really have a good way to deal with that now, because it's mostly geared around things like attaching a heart rate monitor to an app or things like that. But it will be increasingly important as we deliver, CBT-based interventions or things that we know are efficacious via mobile applications.
Thank you, Dave. A quick question that we got was about Myron and the work he's talking about with his App Reviewer Toolkit. That is a function of the Telemental Health Institute, which is my institute. So Myron and I have been colleagues for over 20 years now, working in various aspects of technology and writing together, including a textbook on it. And if you're interested in joining that group, that particular task force, then you can just write to us at contact@telehealth.org, and we will review. We'll tell you about joining our task force for that. Another question that is important as our wrap-up question, and well, I'll give you two more. One has to do with specific recommendations that we would make. We will include those in our written responses to lots of the questions that we've gotten. And that includes smoking apps and stress management apps for children and teens and all kinds of things that we've been requested to provide today. And then the other one I think is particularly important is what our thoughts might be about smartphone apps that actually offer therapy with a monthly fee. And there are a number of them out there. When you're evaluating an app-based service, and a lot of these are text messaging services where they'll do therapy with you through text messaging. I strongly want to encourage you to take a look at whether or not they are adhering to basic ethics of telepsychology or telepsychiatry, distance counseling, online therapy. Practicing over state lines is verboten for no matter what reason. It's verboten, and if you have any question about that, write your licensing boards and ask them if you can practice over state lines. None of us can. So far in the United States without proper registration or licensure in the foreign state or country. So when you see these services that offer worldwide text messaging services to people over state lines by licensed clinicians, you really need to start asking questions. Another one is, are they offering this service anonymously to people? Anonymous care precludes our ability to deliver, to operate as mandated reporters. It's against our requirements as professionals in the United States. So be very careful when you look at those things. And we hope to bring you more information along these lines as we move forward with the APA. Once again, this is Marlene Mayhew. I've been joined by Dr. David Cooper and Dr. Myron Pullier to bring you information about apps. Thank you very much for your participation.